Okay, thank you very much and welcome everyone. I'm Prof Sidhu from London, and I'm going to take you through just an overview of fat disease of the liver. And I'm going to take you through a journey, so don't think you have to remember all the facts and write it down. Don't, just relax, okay? Now, why is fatty liver disease important? And it's going to be really very important over time. And I'm going to take you back about 10 or 12 years ago. Here at the ECR, we were sitting with the Philips group, as we often do, and we have an interactive session with the people, experts in ultrasound and whatnot. And we were discussing fatty liver disease. And we said, well, you know, it's a difficult thing because we're all just looking at it and saying, oh, it's fatty, it's not fatty, it's mild, it's moderate. Can't you measure it? And the engineer said, yes, of course we can. I said, so why haven't you done it? So here we are now, okay? We're here now with a lot of changes have happened over a period of time, and we're going to quantify fat. Quantifying fat is, of course, important. If you've got a patient that comes to you and you say, this is mild, you go and, very severe. You go off, you do your exercise, stop eating, and come back and I'll tell you whether it's better. Oh, we come back, I don't know, it's moderate or severe now, what shall I tell him? You want something objective. You want to be able to say to the patient, you've come to see me, the fat, there's this much figure, and now you've come back and the physician has treated you, encouraged you, it's there. So you're now improving your lifestyle, etc. Okay, so that's one thing. You want some sort of figure that the physician understands and the patient understands. So we'll go through this and I'll show you why some of the figures that are coming through from where Philips and all the other vendors put through are not beneficial to the patient. There's still more improvement to be done, and people are starting to appreciate this. Why is fatty liver disease important? It's an overall risk factor for chronic liver disease. Hepatitis B, you've got a vaccine, so vertical transmission should be reducing. Hepatitis C, you have antiviral therapies, and people are more aware of hepatitis C. So, for instance, in the United Kingdom, there's a big scandal of haemophiliacs receiving blood products 20 or 30 years ago, never checked for hepatitis C, and they have chronic liver disease. 30% of the world's population have a fatty liver. So, look in this room. When we're scanning you guys, some of you are going to have a fatty liver. Fatty livers, it doesn't matter if it's mild, moderate, or severe, it doesn't predict that you're going to progress. So don't you think, it's only mild, it's all right, I can go out tonight, have a foie gras, fatty meal, I'll be all right. It doesn't work like that. And how are you going to survey and look after the 3 billion patients worldwide? You can't do it by MR or CT or anything like that. You've got to do it by ultrasound. And you've got to do it in the primary care scenario, because you cannot. You're going to be overwhelmed. I was at a session yesterday where they can do very good MR, very good CT, but it's the accessibility for that. We do we do surveillance programs for HCC and our chronic liver disease, but overall, the world's population, 25% of people with chronic liver disease have any form of surveillance. So you're not doing a good job, and we're not going to do a job with fatty change, but we should try and do it. And there are many problems with fat quantification, not just from our point of view, but from the nomenclature, and I'll tell you about this. So what is the fatty liver? Fatty liver is abnormal accumulation of triglycerides within the fat cells. And you just have to look at someone to know that they're likely to have a fatty liver disease. Very common in alcoholism, and that's just a separate etiology for it. Women are more prone to getting a fatty liver to men. If there's a family history, if you have fatty livers running back to great uncle Andy from in the last century. In pregnancy, obesity and overweight, high cholesterol, diabetes, hepatitis C, amounts of iron, medications, autoimmune, malnutrition, weight loss, all of this contributes to your fatty liver. And whenever and all of you are seasoned ultrasound people, whenever you're scanning something, you have a surprise. Quite often that this guy's or this lady's got a fatty liver. How on earth did this happen? Okay, so it's going to happen. So what about the nomenclature? Well, it used to be called, and bear with me now, because over the next couple of slides it's going to evolve. This is not hard and fast. It used to be called non-alcoholic fatty liver disease. Okay. Now, I've had problems with this with the dictaphone in radiology, and it comes out alcoholic liver disease, not non-alcoholics. And you can imagine the ramifications for someone who doesn't drink, and you've just called it alcoholic liver disease. So it's stigmatizing. So they had a look at this and decided, okay, we're going to change this. Why are we changing this? So we're going to change it to metabolic or dysfunctional associated fatty liver disease, MAFLD instead of NAFLD. So everyone's been calling NAFLD, it rolls off the tongue. And it's the primary cause for chronic liver disease. But the international experts went in and had an in-depth look at this and decided that it's more accurate to define the spectrum of causing all this and the heterogeneity, to change it to metabolic rather than non-alcoholic. So they changed it from NAFLD to MAFLD. But it's still that same group of patients, the diabetics, the overweight, that have got all this, the metabolic associated liver disease. Okay? Just as you thought you got to grips with this, it's changed again. Okay, so it's not MAFLD anymore. And this is what happened. End of last year, and this is published in a multi-society Delphi consensus statement on new fatty liver disease nomenclature. So this means there's a whole bunch of people, over 100 people, writing to each other over a period of a year, deciding what to call it, why they shouldn't call it this, and why they should call it this. And this is published. And I'm going to highlight what it said, okay? The term non-alcoholic and fatty was thought to be stigmatizing. So this is, in the new day and age, you can't call a spade anymore. So it's no longer appropriate to call it non-alcoholic and no longer to call it fatty. Okay? And this was quite high Delphi consensus. So the name chosen to refer to NAFLD and MAFLD was now MASLD. So it's called metabolic dysfunction associated steatotic liver disease. So this is what you've got to live with now for the moment. Maybe you come back next year and sign up for this course, I'll be telling you something different. And they also subdivided metabolic dysfunction, it rolls off the tongue, metabolic dysfunction associated steatotic liver disease, but if it's actually due to alcohol, it's MEALD. So they've differentiated that from non-alcoholic and alcoholic. So you've got that subdivision as well. So this is how you're supposed what you're supposed to term it as. So NAFLD is now well and truly dead, but you'll see that all the papers and all the studies and all that have still referred it to that, and it'll take some time to change that nomenclature. And this is the flow chart for it. So if you've got liver disease, steatotic liver disease, don't call it fatty liver disease, it's hepatic steatosis in your report, not fatty liver disease. So if you've got steatotic liver disease, SLD, if it's metabolic dysfunction associated thing or MASLD, this is that one compartment. There's no other risk factors for it other than your overweight, hypertension, diabetes, all of that. If you've got alcohol in it and it differentiates how predominant your alcohol is in that thing, you can then term it in that alcohol-associated thing. And then you've got all the other etiologies. So it neatly takes away fatty liver disease or steatotic liver disease from everything else that's causing it. And this is how you look at it. So you've got a steatotic liver, identified by imaging or biopsy. Rarely now are you going to do biopsies. Do they have cardiometabolic criteria? If yes, do they have alcohol with it or not alcohol with it? If they don't have cardiometabolic reason, there's another cause for that, and it's cryptogenic disease or any other disease. So you've got a clear differentiation. It's a little bit clearer now, and you don't get fumbled over those words that may cause offense to your patient. And you only have to, in both pediatric and adult patients, you only have to have one of these criteria to qualify for having a steatotic liver. If you've got a high blood pressure, high triglycerides, and more or less the same in the children, the BMI. As soon as you've got one of these, you're in that category. If you confess to how much alcohol you drink, it may differentiate and draw that out. So you may be labeled with something else. So that's where we stand with how you're going to call the disease with your referring physicians and your patients. Of course, this is not, it's only been out for a couple of months, so it's not widespread yet. So you may not get referrals from your clinical colleagues. They will still say NAFLD on it because everything in medicine takes time to catch up with you. So if we've got, and I put it all here, metabolic dysfunction associated fatty liver disease, MASLD, you have to have absence of significant alcohol intake, presence of hepatic steatosis, exclusion of other causes, and the presence of hepatic fat content should be equal to or greater than 5% of hepatocytes. And this is a histological definition. And that too is going to change. If you've got metabolic associated steatohepatitis, this was NASH, it's now MASH. Okay? So NASH becomes MASH. This is characterized by inflammation, hepatocyte blooming, and you may or may not develop fibrosis. So this is necro-inflammatory change associated with your fatty change, and this is the start of the pathway onto chronic liver disease with your fatty livers. So that settled that then for you. So we've got it all named. So, and then again, just associate MASLD with MASH and with all these underlying issues that you have that will alert you to the fact that you've got a fatty liver. So what happens with MASLD and MASH? So I've said already, you've got 30% of adults in developed countries have hepatic steatosis. And there's a wide variation across the world on what you can do. Of course, if you're from the United States, Mexico, United Kingdom, this is where you're going to have a lot of metabolic issues. If you're from countries where it's less prevalent, and we're doing an international study with South Korea at the moment, and they have trouble getting high-grade fatty change in their studies because there are less and less people with fatty change, whereas we don't have a problem with this. So it's very geographically inhomogeneous. MASLD is simple steatosis, and it's not anything, no inflammation in the liver at all. You can't actually see that with your ultrasound examinations at the moment, but this is going to change. Viscosity measurements may change over the time to actually allow you to measure inflammatory change. But the hepatitis, the MASH as it's called now, can be present in up to a third of patients with steatotic liver. And this becomes more important because it then puts you at risk for HCC. Okay? And the HCC that commonly or more prevalent in patients with steatotic change is a histological variant of HCC, which is not so easy to treat as the conventional hepatocellular carcinoma. So you've got a problem brewing here as well. So you may get a different variant on it. And this is taken from a paper some time ago, I think it was in the early 2000s, in 1995, when it was still noted, to show you the levels of development of the progression, and it was still called all that, of the disease of hepatic steatosis into inflammatory change, into fibrosis, into cirrhosis, and into HCC. Now, the sheer number of patients with changes in the liver of steatosis will make this a volume problem. So you've got far more people with an underlying issue with the liver, and therefore you're going to get more and more people there. So the liver clinics in King's, where I work, the demographics of the patients changing because people have been treated for hepatitis C. Hepatitis B in the United Kingdom is not so prevalent in the indigenous population. It's more in the immigration population. They bring it with them where they haven't had vaccination or haven't had an opportunity to have vaccination. So we're in a transition, but this will change, and it will become alcoholic-related liver disease will always there. autoimmune disease, other causes are almost there, but they're not going to alter dramatically. The population is not going to suddenly stop drinking alcohol. If anything, it'll increase a bit. But that fatty change is not going to change. It's only going to increase. So the volume of HCC generated by this chronic liver disease is going to increase. And we see it already. Transplantation for cirrhosis from steatosis, HCCs in the thing in steatotic livers. So it's a big problem. But whereas radiologists, we can quantify this, and this is what you're aiming to do with all these parameters. The gold standard, and the standard even for gold standard or reference standard for fibrosis, it was biopsy, is changing, but the gold standard for steatotic liver is a biopsy. And you classify into grade 0, 1, so it's S0, S1, S2, S3. And this more or less equates to mild, moderate, and severe. Those famous terms that the radiologist uses, moderate, yeah, this, the complete estimation. And the range of fatty change is quite wide. So anything less than 5% is considered normal. Then it's 5 to 33%, 34 to 66%, or greater than 66%. 66% of fat in the liver is astoundingly high. It is incredibly high. But then think and roll back a bit. Okay, this is histology. This is a pathologist looking at a slide and telling you on that slide, I think it's 6%. Okay? Maybe they've got some AI tools now that will estimate this for you and say it's about this much. So even though we think we're subjective, I'm going to just pause to allow people to sit down. I don't think there are enough chairs. Yes, there are. Just about. There's one more chair here. So when you think of it, you've got someone estimating for you how much percentage of fat there is. And this, we think, is the gold standard. So clearly it is not the gold standard and will not survive as the gold standard. But whenever you do research and publish something, you relate this to the gold standard. So up till now, biopsy is being considered the gold standard for measuring your fat quantification. But there is a better gold standard than this, and this is what we use in research projects, and this is MRI, but we'll come on to this. So this will probably disappear, just as like liver biopsy for fibrosis is going to disappear, because you're compartmentalizing the degree of steatosis or the degree of fibrosis based on an individual subjective thing into a compartment. It's a continuous issue. So if you have a figure that gives you that measure on a continuous thing, you are doing better. So we're seeing this with fibrosis, measurement of the shear wave elastography, 2D. Trying to put it into a compartment is difficult, but do you need to be in a compartment? You just need to know where it is on that thing. And same with fat, you just need to know where it is on that, and if you're treating it, is it going in the right direction? Okay, so this will change. So this will probably take 3, 4, 5 years before it changes, before there are multi-center studies that come out on this. So it's still the gold standard, it's still the reference standard, and we still do biopsies at King's for in the level of hepatic steatosis when all the results are not coherent. So what have you got for it? Remember, this is rapidly evolving. Conventional ultrasound you can use to look at the fatty change. You can use CT, you use MRI, but you've also got elastography and other quantitative ultrasound techniques, magnetic resonance elastography, and other MR-based techniques. So you've got lots of tools now in your pocket to look at chronic liver disease and give clinicians and the patients some idea of what you think of the degree of fibrosis or quantification. On CT, and it's supposed to be more specific than ultrasound, but it's ultrasound without the quantification. And it relates to the level of triglycerides content, and you're relying on the attenuation values. So those low attenuation values tell you it's a fatty liver. Now, you're not going to do CT on 3 billion patients to look at fatty liver disease because it's not so good at the lower levels, it's not as sensitive, And it's just absurd that you would go and do this. So yes, it's a nice tool. You can see it's a fatty liver. The quantification methods for it are not accurate, and it doesn't detect low levels of steatosis. So yes, we've got that tool. We're not going to use it. Radiation burden, and I relate this to a radiologist. Should you be not doing so much CT? Yes, you shouldn't, but it's good for the patient. We do a lot of CT. Relate it to climate change. I drive my car. It's not going to make a difference to the climate change. Everyone says that. But if you're going to CT every patient who doesn't need a CT and you have another imaging modality, you should be doing that imaging modality because you reduce the overall burden of radiation to the population. Same argument. What you are going to use, and you're going to use this more often, and it isn't a difficult MR technique to do, and it gives you very accurate quantification, and it gives you the whole liver quantification. A biopsy gives you a very small part, and we all know fatty liver disease is very patchy. MR gives you that global view. But is that global view useful to the treatment of the patient is another matter, because you've previously been treating fibrosis on that small sample successfully. So does it make a difference if it's variable across the whole liver or not? That's a philosophical question. And the same now with fat quantification. But where this is useful is it is accurate, and it's been accurately matched up to a liver biopsy and shown to be very good for it. And we use it now as a tool in commercial studies or research studies where there's follow-up of fatty change. And this will become your reference standard for hepatic steatosis. But let's have a look at ultrasound and see how it goes. So everyone is familiar how ultrasound is inexpensive, non-invasive, and you can do that qualitative measurement, that subjective measurement. But it's so operator dependent. It changes the patient's body habitus, and there's so much difference between what different people look at and tell you what is good and what not. And how do you do this on just the base ultrasound? Well, most of you just eyeball it and decide this is what you're going to do. But there are ways you can look at it more objectively with just the plain ultrasound. The liver-kidney contrast is the most common one, the dark kidney, the bright liver. Vessel blurring, posterior beam attenuation, focal fatty sparing, and you can't see the gallbladder and diaphragm visualization so right. And then you say, this is fatty change, this is steatosis, because the liver is bright. And then you gauge it on your mild, moderate, and severe. Is this an accurate way of doing it? Yes, if you're an expert and you do it all the time and you talk to each other and do this and you're consistent. And this, this has been shown in studies of experts that they more or less agree on it. But it's not going to be universally distributed. You can't do it. And there is no point in just saying mild, moderate, or severe. No point. But it's a time-honored technique, and we will always use it because it's there in our mind. So that's there and available. But there's limitations, okay? And we've been through all these limitations before. You can't see a lot of things. And it's said that in this sort of B-mode ultrasound, it's got to be 20% of hepatocytes have got fatty change in it on histology, that you actually see it. I think this is a little bit too high. I think it's probably less than that. But this is what the literature quotes. So what have we got coming up for fat quantification in the liver? When you've got an ultrasound beam that goes through the liver, it does many things, okay? And the amplitude and the variation of the frequency and the degree of skin sound and the speed of sound all influence this. So the more attenuating your liver, the brighter your liver, the more attenuating it is, so the beam doesn't go through. So this is attenuating. And the backscatter from it changes as well. And the speed of which that sound travels to the liver also alters. So all of these parameters can be used to quantify fat. You can also use the difference between the liver and the kidney as the hepatorenal index and quantify that as well. Okay? And there are vendors who do this for you, and it's AI, and it puts it on the cortex and the liver, and it measures it for you. So these are what we have already in our tool. It's just a matter of teasing this out and quantifying it for you. So hepatorenal index has been around for some time. People used to take it off the machine, put it on another PC and calculate it. And this paper in the AJR about 10 or 15 years ago now, 2013, about 11 years ago, actually looked at this and quantified it and gave you figures to say whether it, and correlated it with the fat on histology to give you some sort of figures. This is variable. It's a useful tool because it's quick, and if you see a fatty, you can say, well, the kidney is 2.8 times, liver's 2.8 times brighter than the kidney. It gives some sort of quantification for you. So it's not it's a valuable tool in that because it's rapid and easy to use, and it's better than your mild, moderate, and severe. And a lot of machines have this on it, and I use it quite often just to give an idea, to the patient quickly what is going on. So you've got that, and it's not completely inaccurate, but you have more accurate techniques. And remember, if you've got underlying chronic liver disease, this is not of any use at all, because your liver kidney is going to be echogenic and diseased. You can't measure it against it. What else you got? You've got attenuation. Very simply, the attenuation is how the beam is attenuated through the liver, and if it's brighter, it's going to be more attenuated. And this depends on the frequency you put in. So the measurement parameter is measured in decibels per centimeter per megahertz. So the equation gives you 1.08 megahertz per decibel per centimeter, and as a quantification. It gives you a number, so attenuation number. But this is not something that the patient is going to appreciate. If you tell him you've got an attenuation value of this, this, and this, they're not going to appreciate that, nor is your clinical referral going to appreciate it. It's great for research techniques, and it's great to quantify things, but it's not going to give you anything that one. So attenuation is the one that most of the vendors have on their machine, and it's the one that's most looked at. Then you've got backscatter, and this is a little bit more difficult to do. You're measuring the scatter, and attenuation is involved in this measurement as well. And some of the machines use the backscatter up against a phantom, and there's no numerical you've only got a numerical value to this as well. So that's backscatter of machines, and the papers at the bottom are the ones that you do it. Then you've got the third technique, the speed of sound. Now the speed of sound is actually interesting, but whether or not it comes to clinical fruition is a different matter. It's been around for about 30 or 40 years, and it's well known that there are different speeds of sound through different tissues, but we all assume it's 1,540 meters per second, full stop. But if you've got a lipid content that is increasing, speed of sound is slower. But look at the values, it's very, very marginal. Okay, so you've got to have something that's sensitive enough to measure this change. And you have got something, if you've got something that's sensitive enough to measure this change, it's very accurate. But at the moment, you need something that doesn't vary more than 1% to be accurate, and you haven't got that. So this is still a lot of work. And Jeff Bamber's the one from the Royal Marsden Hospital in London who's worked on this for 30 or 40 years. But you can see how it does change in different speeds of sound, but it's still not inaccurate. So you have that tool as well. And there is one machine that uses this in clinical use. So what have we got at the clinical practice at the moment? And I'm only going to go on for another 5 or 10 minutes because I know you're all exhausted after the meeting. So this is this is not the most up-to-date because it evolves all the time. Every time you come to a meeting like this and come and see a vendor, they've got something new on there. You never know what is in there because the vendor's not going to tell you, but the calculations are made. And this causes a problem, like it has caused a problem with the measurement of fibrosis. You don't know if it's transferable between different machines. And I think we're only now teasing out with quantification of fibrosis that whether the figures between the two machines can be equivalent. Controlled attenuation parameters on the FibroScan. And if those of you who are familiar with FibroScan, this is a hepatology tool. It's an office tool. It's a standalone machine that has no ultrasound capabilities for visualization. So you don't see any of the organs. You're just putting the FibroScan in the intercostal space on the right, and you're hoping the liver is there. If there's ascites, you don't get a measurement. If there's waistline obesity, you don't get a measurement. It measures in kilopascals, and the Young's modulus equation measures it in meters per second. So meters per second is converted to kilopascals, and then is inaccuracy in that measurement. Radiology machines all measure in meters per second, which is the correct thing, but you can toggle between the two. But it's established hepatic hepatology practice, and it's been around for 20 years. The first paper was published in 2004 in Ultrasound Medicine and Biology, and since then it's caught on. But the FibroScan can also measure the controlled attenuation parameter, and it can give you a measurement of fat as well. So that is there and is being used. And you look down the list, you can see that most of them are measuring decibels per centimeter per megahertz, which is attenuation. Depends on the megahertz of the probe you're using. And there are one or two machines that look at backscatter, and speed of sound is down as Hologic United States, but as of November, they removed the ultrasound machinery out of Hologic, and it's now back again as supersonic standalone. So it's now standalone machines, speed of sound in clinical use. Some of the manufacturers combine these, and Siemens there has an ultrasound-derived fat fraction, which combines their method of measuring backscatter and with the attenuation. You can see now why I'm saying don't hold your breath with all of this. It's going to evolve and settle down over the next couple of years. For my point personally, I think, and for the patient, a fat fraction measurement in percentage terms is the most useful. And this needs to be validated clinically as well. So if you say to the patient, I've looked at your liver today, you have 14.82% fat. You go around, run around the block, come back and see me next week, and we'll see what it is. Patient comes into you and says, well, it's 10.1%. You're doing well. See how the patient understands. And he goes out next door to the bar and has a few drinks, and he comes back and it's 14% again. Okay, so you have an interaction and the ability to get the patient to understand what's going on. And also, the clinicians will understand better what percentage you have in the thing. But if you tell them, oh, it's 1.8 decibels per centimeters per megahertz today, you don't understand it. So you have that thing. Even though it simplifies it in a manner, you've got something that's transferable and understandable by all who are using it. So I would encourage all the companies to do it. And this is changing, as I say all the time. There's no standards yet to tell you what is and what is not good practice. This is the FibroScan, the controlled attenuation parameter, and they have figures, and they measure it in decibels per meter because they have a standard probe. There are different probes, but usually it's the standard probe on it. And the cutoff for steatosis is 288 decibels per meter, and they give you these figures. This is probably only about 60% accurate thing, and this is recognized. It is not the most accurate method of measuring fat. The sensitivity is lower than the attenuation coefficients that are measured on proper imaging ultrasound machines where you're looking at the liver and you know what you're looking at. And sensitivities for attenuation coefficient compared to steatosis and PDF, 76 to 84%, 87 to 79%. So getting quite high, but still not fantastically comparable, but coming. And the limitations are, if you use this, and you're going to use most of the machines that you're going to use are attenuation, and the limitations are there are no specific cutoff values. So when you're using it, you don't know what you're cutting it off for, at what level. You just don't know yet. And different studies, different machines show differences. And there's no consensus of box. So you've got an ROI, a region of interest, and where you should put it. This is changing. I'll show you on a little bit slide. There is some more consensus coming through. And they don't know where you, just like with scanning for fibrosis, you put a box. Where did you put the box? You didn't want to put the box too near the liver capsule, the region of interest, because it's stiffer nearer the capsule. If you had a depth from the skin, how deep do you want to go before you lost the ability to measure accurately? Because the deeper it goes, and the same with the fat, the deeper you go, the less accurate. Of course, that's going to be. Your attenuation measurement is going to change considerably through a very fatty liver all the way down. So you're getting less and less signal to Royal noise ratio, and your measurements become inaccurate. So it has the same thing. And there's no consensus yet on the number of measurements you take. In fibrosis, we took 10 because why? FibroScan did 10, so everyone did 10. We produced a paper published in Radiology, said you only need 6, and you say it's accurate. So now you go down to 5 or even 3 with 2D elastography. How many do you need in fat? Who knows? Certainly not 10, but certainly less than that. Backscatter, there's less information out of there, but it seems to have a little bit higher sensitivity and specificity in some of the studies done. So watch this space with backscatter, and certainly with the study we're doing at the moment, backscatter does really reasonably well against attenuation and sometimes outperforms attenuation. So backscatter may also be useful, but what about combining the two, as people have done? Combine the two, make the most of it. And this is what we have at the moment. Remember, it's coming up for MDF. There's hardly anything out there, clinically wise, for speed of sound. And, you know, the studies on healthy volunteers give you sensitivity of 90%, a specificity of 95%. It's pretty good. But how will this perform in cirrhotic livers, in steatotic livers, where the speed of sound changes are so small? Are you accurate in measuring it when you've got clinical factors in there? Healthy volunteers, of course, are healthy volunteers. Phantoms are phantoms, and that's all very, very accurate. So what have we got? Well, we've got one system out there that combines attenuation and backscatter and gives it as a percentage of fat. So we've got one, and this is reasonably accurate compared to MRI and PDF. But the cohorts of patients that they've looked at are small. So you've got to wait on this a little bit longer. But it does give you that ability to relate to the patient and clinician. So I think probably over the next few years we'll see migration to this sort of measurement with all the background information available to you, but the headline value shown on your machine. So what is the protocol for fat attenuation measurements? I know this is coming through because I've got the paper on my desk as editor of Ultrasound Medicine Biology, and it's accepted for publication, and it's the guidelines from WFAN. So these are coming through. And this is what they recommend when you're measuring fat attenuation. You don't need to fast, but if you're going to combine it with your fibrotic measurements, you're going to fast because you need to fast for fibrosis. So you might as well do both together. You need breath hold. Breath hold means not breathing in or out. You need the transducer perpendicular to the liver via the right intercostal space. So exactly the same as you did before. Try and keep that box parallel to the capsule, though it's just not needed quite as sensitively as the fibrosis scan. Your B mode image should be good. If you've got a rubbish B mode image, you're going to get a rubbish measurement as well. So you've got to get your B mode accurate as well. Size and place in the measurement box, about 3 centimeters below the 2 centimeters below the capsule. But the box is probably they're going to come out and say it should be 3 centimeters. But at the moment, a lot of the boxes are 4, and that's not going to make a huge difference to it. And the larger the measurement box is advantageous. It's just that you need to place it away from the capsule, away from vessels. You want to keep as many vessels out of there. And you have a confidence map, like the Philips machine has a confidence map. All the machines have confidence. We tell you how suitable that measurement is to be made. And this should have at least a 60% confidence that you're getting a good measurement. 3 to 5 measurements is the thought. Probably end up doing 5. And your interquartile range measurement, quality measurement, should be less than 15%. At the moment, some guidelines say 30% for fibrosis. Newer guidelines say 15%. It's almost impossible to get readings for your FibroScan below 15%, but certainly you can do it with your ultrasound machines. So when you're doing fat quantification in clinical practice, what should you be able to do? Well, it should be simple to use. So it's one button, you get your measurements, okay? At the moment, you're doing 3-5 measurements, and this takes 3 or 4 minutes to do, or 3 minutes to do. But if you're doing a clinic where you're examining 3 billion patients, you don't want that 3 or 4 minutes. This expands to greater than your lifespan. So you want something that's very rapid. And vendors are coming out with a one button that does the whole quantification package for you. And that same button can do your elastography for you as well. So this is all coming. and it's workflow that improves. And it should become, therefore, part of your routine examination. Like you're measuring the length of a kidney or you're measuring the portal vein velocity, this should take less time than that. And this is probably more useful than the portal vein velocity that you measure. And it has to be rapid, accurate, and reproducible. So this is coming as well with all the studies. And you should have transferable measurements. So you're using one machine, you use another one the next time, you're getting the same ballpark figure for all of them. You can't expect people to be using the same machine each time on the same patient in a big busy department. It just doesn't work like that. And you've got to simplify it. So, think of the fat percentage is probably simplified. So I'm going to end up just telling you now that in clinical practice what you've got as a one-stop clinic. You've got your B-mode ultrasound for liver examination. So you can look at the liver parenchyma, the liver surface irregularity, and you can see focal liver lesions. You've got your color Doppler, you've got your spectral Doppler, and you've got microvascular imaging now, which tells you the unique features of tumors, vessels, the hepatic artery, all of this very carefully. You've got contrast-enhanced ultrasound, which you can use to characterize those focal lesions to really quite a high standard. You've got different types of elastography, point shear wave, 2D shear wave elastography, now proven, very useful for looking for fibrosis. And in fat quantification, you've got all of these coming through. Some will fall off by the wayside, but probably a combination of factors with a percentage, and you rapidly do it, you've added to it. So what are you missing from your comprehensive liver ultrasound examination? Measurement of necroinflammation. This is that the old NAFLD going to the NASH. You can't tell this on your ultrasound. You can't tell there's inflammation. Some other parameters like liver biopsy can. But this is changing. This is coming. The measurement of viscosity in the liver will tell you whether there's necroinflammation or not. You don't have a non-invasive measurement of portal hypertension. This is extraordinarily important in chronic liver disease in children, because the only definitive way of measuring portal hypertension accurately is transjugular puncture wedge pressure measurements. But this is changing as well. You can tell the portal pressures externally with ultrasound, and this is done from Fleming Fosberg out of Thomas Jefferson, and he's publishing quite a bit now. And you can tell by looking at the acoustic pressures of sinusoid, not sonoview. Sinusoid is a microbubble that's got a bit better shell, and you can measure the acoustic pressures in relation to the portal vein pressures, and it can give you an estimation of portal pressures. This will be a game changer for those people who rely on knowing, because management changes once you've got portal hypertension in these children. So that's coming as well. And it's all multi-parametric ultrasound, so it's all going to make you the best practitioner by looking at chronic liver disease, because you can do it all. You don't need to do anything, and cheaper than any other imaging modality. More available, and you have people who can do it in the primary health care. Why are you scanning someone in your tertiary referral hospital for fatty liver disease if you can do it as a point of care in primary health care and triage the patient there? So it's going to change. And you can't argue it. There's just too many people to be scanned to say no. So what's the conclusion? Well, it's the new pandemic of liver disease. It's more dynamic than fibrosis. So fibrosis is probably just progresses all the time. It's unlikely to regress. But hepatosteatosis, it can change during the week depending what you're eating. So that it's much more dynamic, and therefore you've got an imaging technique that's repeatable without any problem to the patient. It's going to increase as viral hepatitis decreases, and it's going to be the cause of more of HCC. Then you've got MATALD now, which is alcohol involved, and moves away from your imaging as a different category as well to be managed differently, which is about time, actually. And the severity of the disease doesn't affect your progression. So even if you've got mild, you could progress. And this is the most alarming thing, because doc, you said it's mild, I'm okay then. Well, you're not. Yeah. And ultrasound is always the most cost-effective disease. And now you've got objective quantification, which is far more desirable than your subjective quantification. The entirety of the liver can be assessed by ultrasound, but you can't measure the entirety of the liver with your quantification. It's just not possible. MR will do that for you, but liver biopsy never did that for you. And all the necessary parameters that we've talked about are in clinical use. They are being used, even in an even speed of sound. But most importantly, it's patient-friendly. Your patient comes in, sees you scanning them, you tell them what's the problem, you tell them that they've got fatty liver disease, you tell them it's okay, you know you've got a focal liver lesion, I've given you contrast, it's a hemangioma, don't worry. Compare that with the patient going to CT or MR. The technician puts them in a gown, puts a line in, puts them in the room. It's all cold, quiet, bang, and the noise starts, and then they inject contrast in CT. It's hot everywhere. They see everyone watching you having from the thing, and you lying there. And then the door opens, and someone comes in, takes the cannula out, presses on that. Bye. Someone will be in touch 2 weeks with the report. The difference for the patient is phenomenal. Just put yourself in that position. You want to know what's going on. And then if I'm scanning and I find a focal liver lesion, do you think the patient doesn't know you found something? Yeah, they're watching you. You're scanning. What are they going to do? They know it's there. So 80-90% of focal liver lesions are benign on things, so you can do that as well. And the difference is that if you're a radiologist, don't complain that the patients don't know who you are. Because you don't see them in CT, but you see them in ultrasound. They know who you are. You're a radiologist. Never seen one before, but you're great. Okay, this is what you want to hear. Okay, so, and it's rapidly repeated with no problems at all. So that's where fat quantification is, and I'm just going to leave an advert up for you who are pediatrics, and that's all I'm going to say today. Thank you. So I'm happy if you ask me any questions, but I think we have models. And we have clinical specialists who are going to show you how to do it, okay, on the thing. So get yourself to the machines, and I'm here if you want to stop and ask me any questions.
What options are in this machine?
No, it's all turnkey. So once you purchase the license, you get the number. It's just like Microsoft. You purchase Microsoft, you get the thing. And it's not expensive. I mean, I'm not going to give you a ballpark figure, but in comparison to the entire machine, it's not expensive. Yeah, and to think what you can do with it, is more important. And if you're in private practice, of course, this becomes an additional cost that you can thing. In my personal opinion, this is more important than your elastography. Yeah. So do you want someone to come in here? Come on guys, come up here. Are you going to scan, or are you going to get them to scan? Come on, someone come here and scan. The inflammation affects the fibrosis more than the fatty quantifications. So at the moment, you don't know whether that, and it may become important because the inflammation may be the reason for progression in mild, okay? Yeah, so you don't know that. But in a couple of years' time, you will be able to tease out macroinflammation and have a figure for that, and tease out fat and tease out fibrosis. So you'll have separate figures for that. The amount of fat in the liver doesn't affect the fibrosis scan. It's independent. The measurements are independent. Yeah. So it's only the hepatitis that you need to know about. I'm not the NMR expert, so I can't tell you what they do. Yeah, I think, but they use it to a very standard protocol. Okay, so you want to make sure there's no river shadow. So this is perfect, okay? And I don't know how they quantify on this one. Let's see.
I don't have shear wave on the show.
Where's their shear wave on this one?
Should they call the application specialist?
I don't know where they are. Let's have a look and see. Liver quant, there you are, okay?
Okay.
Now you press liver quant first, find the thing, and then liver quant. Okay, so you want it there, okay?
Okay.
This is, I think, elastography.
3 cm from the capsule.
This is elastography rather than fat quantification.
Yes.
What you need to do, okay, is to make sure when you keep it there. Okay, get it there, and try and get the whole of the thing covered with your color. Okay.
Color box.
Yeah. Bring it down. No, don't get him to breathe. I tell you how it comes up. Let me see if I can. I don't know where the things are, but I can show you. I'll show you where to do this. Because if you breathe, you increase pressure in the
Like a clock.
yeah, that's right. Yeah. So you choose the area that your confident map is best, and you want to avoid the vessel. Right? You should be able to just alter the circle diameter as well. Oh, there you are. Okay. But usually it's bigger is better. So there you put it there without any vessels, and you're getting a better thing. Okay? And you do it 5 times. Okay. So now we have to find the elastic Q. Okay. So get your depth a bit more. You're going to try and get the thing. Okay. Now you see there. Okay. You can scroll, so you can go backwards and forwards to get the better picture. If you want to see the confidence map on here, which is the best area? The red is no good, it's the vessel, yeah? Yes. So then you've got the circle diameter, okay, and you're going to measure, and then you can put it where you think it's best.
Yes.
Yeah, see how again it'll change where you put it. So you want to be confident of where you're going to put it. That's the best reading you think is the best reading, or the most accurate. And again, when you press enter, it'll enter it here, and you can do it 5 times. Okay?
5 times.
Five measurements.
No, you stop,
Stop.
otherwise it's cheating.
Take
Okay?
another measurement.
Yeah. And you see how this one is not so good, and the confidence map shows it's not good, okay? And even though it's not all, this is fine, because you know that you've got one area that is okay, so you can make that measurement from there. Yeah, but you're not going to make your measurement from here because it's not accurate. Okay, just stop breathing there. And breathe away. And stop again. Okay, there you are. All right, and this you got. And you can scroll until you think, oh, that's a good image. Then you can measure.
Also circle.
Yeah, you circle, measure, and then you want to put it here. Yeah, which is the best. And then you get the consistent reading.
6. Okay, depend on the number.
Yeah, but this is not a clinical environment. I'm not going to make a diagnosis. They're trying to make me tell you you've got liver disease. No. Okay.